So I'm just going to go through some of the things we discussed, but maybe in a bit more detail. So essentially the terminology, so trigeminal, okay, refers to the actual name of the nerve that is affected by this disorder. Okay, it's a trigeminal nerve, which is the fifth nerve that connects the brain to the face. So it's really a nerve problem. And neuralgia tells us that this is a nerve problem. It's essentially describe a pain. That's what neuralgia means, a pain that is due to a nerve that we discussed earlier. The characteristic nature of the pain, so classic trigeminal neuralgia, is really felt as a severe facial pain, which only affects one side of the face, and it's really sudden. The classic description is electrical or even stabbing. We've discussed in name as a suicide disease. The trigeminal nerve itself has 3 branches, which are labeled V1, V2, V3. And these are the 3, that's how it's called trigeminal, tri for 3. And these are the branches that are affected by this, and its face, and where it's felt in the face. Correct? So any one of these branches can become affected, or combination of them. Okay, it has been described in the medical literature as one of the worst pain known to people. In terms of how the frequency of it, it's not a pain that's there all the time. You know, it really comes and go, and it can happen several times throughout the day. So people will have attacks of this pain throughout the day, with it going back down to a baseline pain sometimes in the more severe case, but it could also be pain-free in between these attacks. And the attacks typically last 2 minutes or less of very excruciating pain. Now, in terms of what can trigger the pain, okay, very simple things. Now, patients are extremely sensitive to anything that would trigger the nerve in the face. Okay, so there will be things like really simple things like in the morning, brushing their teeth, cold water on their face when they wash their face, simple things like talking, smiling, laughing, eating, chewing, swallowing. All these really trigger the pain, and patients try to avoid these kind of triggers. So they will maybe talk less when they have the pain. They will really not eat or even avoid brushing their teeth on that half of the face. In the kind of severe form of it, people describe this as a power drill, like really someone trying to drill out their teeth. Okay, and which is why a lot of patients, maybe over 60% of patients, go to see a dentist first, and they may be diagnosed with a cracked tooth. You know, and this is what really happens. So it's like a dental presentation is not uncommon. Then the dentist may occasionally, you know, remove the tooth, and the pain doesn't go away. You know, and that's when they get the diagnosis of trigeminal neuralgia. In terms of frequency, it can be a few times a day, but in the worst case, it can be up to 50 times a day. And you can see why it has traditionally been called a suicide disease. These are patients getting really severe pain up to 50 times a day. And we already discussed this. It's really, you know, it's like a toothache. And some patients, you know, it's really, really severe. Now, what we need to discuss next is what's causing it, correct? What's the pathology of trigeminal neuralgia? And what it is that it is, and this was not known for a long time. Even though the disease was described for hundreds of years, no one knew what was causing it until you know, the 1970s, when people then found out that this was because of a compression of the nerve by a blood vessel. So it's essentially what is sometimes described in the spine, where people may have a pinched nerve, but this is like a nerve that is pinched or compressed in the brain. And this is the pain that is felt from this. And the most common cause of that compression is from a blood vessel, which is shown here. There are some other causes that may cause this compression, and the other one, which is a bit rarer, is tumors. Some brain tumors, you know, that can also compress the nerve. So this is what, when you see a doctor, you know, we must really be aware of, is this being caused by something else? For example, a brain tumor, and rarely multiple sclerosis as well. So we've discussed this. It affects patients in their 50s, generally 0.3% of the population. More common in women, about 3 times more. Right side more frequently, and tend to affect the mandibular branch of this nerve, so which is the V3, so the third segment, which is mainly in the in the jaw. In terms of how we diagnose this, so really the main test is a neurological examination and the classic history of patients. So the diagnosis is really clinical, meaning that there's no MRIs or other kind of tests that we can do to really diagnose this. It's really about what the patients tell us and what we find on our examination findings. And this is what an MRI would look like if you had, if someone who had trigeminal neuralgia. So the nerve is here, and a little dot here is a blood vessel that is compressing the nerve here, and this is what it looks like. And there are different MR sequences that can be used to demonstrate this. So what we want to see is a patient with a classic history of trigeminal neuralgia, MRI that confirms a compression, and absence of other signs. So for example, if someone has numbness, that usually is not classic trigeminal neuralgia. It could be tumor, for example, or multiple sclerosis that may give them additional features. If someone has other signs like clearing of the eyes, again, this is not likely to be trigeminal neuralgia, but maybe more of the migraine type, headache type problems. Yeah, so there's a range. If the pain, for example, is felt all the time, and it tends to be around the ear, near the jaw, then maybe it's more a mandibular joint problem, so a joint problem then. So these are kind of what the doctor would go through. They'll try to eliminate other possibilities and try to get down to the diagnosis of trigeminal neuralgia if that is the problem. I think the main thing to know in terms of treatment is that even though the pain is really severe, it is actually treatable. Right? People should not despair that, just because of its severity, it doesn't mean that it's not treatable. Right? There's no correlation between severity and treatment here. Okay. First line treatment, like in anything medical, is kind of, tablet-wise. So most of the time, most doctors will try to treat this with medical therapy. The most useful drug to use is an anti-seizure medication called carbamazepine or Tegretol. And that works for about 60%, 70% of patients. And some patients are able to take this for many years before it stops working. But for many patients, after several years, it doesn't work so well. The efficacy decreases. They have more and more pain. We have to increase doses. They have side effects. And that's when you have to think of the other options. Yeah. So about 30% of the time, people are looking for other options, and these are the three ones I'm going to go through, maybe briefly, because there's a lot of details there, but I'll just go through briefly. So surgery is one of the options. So tactic radiosurgery, radiation treatment, and a lesioning procedure called rhizotomy. So medication we've discussed is the first line. It helps control the symptom palliation, controls it, but doesn't really cure it. Treatment is considered when the pain is not well controlled. Side effect can be quite common. Some patients take this carbamazepine and they really can't function. They find that they are extremely sleepy. The memory is very affected and they can't work. And some patients really just do not want to be on lifelong medication. In terms of non-invasive treatment, so stereotactic radiosurgery. So this is a radiation treatment. The kind of results are about 3/4 of patients have immediate pain relief, but long-term pain control not so good, about 70%. There's a risk of facial numbness. That's a key problem with this. And essentially the beams are multiple beams focused on the nerve, and it destroys the nerve and affects its function so that the pain is felt less. Similarly, the ablation procedure is putting a needle into the nerve. Because it works faster, you get pain relief initially much faster, 90%, but no long-term control and facial numbness in the pain area. And again, it's using a needle that goes through the cheek, and you target the branch of that nerve because it's a nerve problem. The next one and the final treatment I'm going to talk about is surgery. And surgery is considered minimally invasive, small opening at the back of the head, and potentially it's the only one that cures the problem because it does not really destroy the nerve in any form. And targets the nerve root compression, 90% initial relief. What I mean by initial pain relief means the very next day. Yeah, so the very next day the patient is pain-free, so it's that instant. And long-term, about 80%. Side effects are, in terms of neurosurgical procedures, considered to be fairly minimal. And essentially the surgical procedure is quite straightforward. There's a nerve and a vessel that is compressed that we've shown before here. And the idea is just to put a little sponge, a little cushion to separate the nerve and the vessel, and that usually does the trick. Yeah, so it's a procedure that takes about 2.5 hours to do this procedure. And this is what it looks like under our microscope. So this is an actual nerve here, and we've put a bit of cushion around it just to pad the nerve. And the incision opening is behind the ear. In terms of comparison of outcome, this is the decompression procedure. You can see it has the most lasting outcome for longer period of time compared to the other two types of procedures. The radiosurgery, which is the radiation treatment, takes some time to work and then it decreases. The rhizotomy initially really works really well, but then it quickly drops down. So in summary, medical treatment first line, followed by these other treatment that we have discussed. And I think surgery, if possible, in younger patients tend to be the gold standard treatment. The other treatment we tend to reserve for older patients. Okay, so I think essentially it's about having an individualized treatment plan and really finding the right treatment for the right patient. Thank you.